Good morning, good afternoon, and good evening, everyone. And thank you so much for joining us for this last session in our TB Genomics series that we've been running. We gratefully acknowledge the Gates Foundation for funding these echo sessions, and we are grateful to all of you for making the time to attend. So this is the fifth and final session in the TB Genomics series, as I've mentioned, and we're currently running a brief poll that you could please share your feedback on the sessions. Tell us if you've attended any of the sessions or if this is the first session that you are attending. And as you do that, I would like to just remind you of a few housekeeping items. The session is being recorded and it will be for 1 hour. Fitsam, please run the poll. We will start with a presentation from Dr. Lestari, and that will be followed by 10 to 15 minutes where we will have a question and answer section. To join the discussion, please put your questions in the Q&A box. You'll see it in your Zoom toolbar. And also you will find in the Zoom toolbar, you have an interpretation menu. Please, if you can select whether to be in the English channel or to be in the French or Portuguese channel as needed. You get translation in French and in Portuguese, but if everyone else can please select the English channel. The sessions and the session slides and the recording of this webinar will be shared with all registered participants after the webinar. And if you require a certificate of attendance, this will also be shared with you. You'll receive an email with a link to download that certificate of attendance if you need it. So again, a very warm welcome to this fifth and final session in our TB Genomics series, where we've been exploring how national TB programs can scale up the use of targeted next generation sequencing, which is recommended by the WHO for the rapid detection of drug-resistant TB. So we initially started with an overview of the policies and regulatory frameworks, as well as the tools that are available, and with those presentations from the Africa CDC and the Foundation for Innovative and New Diagnostics. We then started the country presentations, beginning with Eswatini, and the previous one was with Mozambique, where they really demonstrated the value case for targeted next generation sequencing in detecting drug-resistant TB and informing appropriate management. If you missed any of those sessions or you'd like to recap on them, we'll paste the link to those sessions in the chat, and you could then go and view those recordings. We're therefore honored today that we have Dr. Bony Lestari to close out this series for us. Dr. Bony Lestari is from the Department of Public Health Sciences and the Division of Epidemiology and Biostatistics at the Faculty of Medicine at the UNPAD. I would pronounce it, but I probably would not say it correctly, Dr. Lestari. She's a medical doctor with 25 years of work experience. She has a master's degree in clinical epidemiology from the Erasmus University in Rotterdam, the Netherlands. And she also has a PhD focused on tuberculosis from the Radboud University in Nijmegen, the Netherlands. She is a clinician and a public health practitioner, a researcher and a lecturer, and her current research interests are primarily infectious disease control, epidemiology, implementation, evaluation, and quality of care. Her work has primarily involved planning, organizing, budgeting, monitoring, and evaluating different infectious disease programs. Currently, she is based at the Radboud Institute of Health Sciences in Nijmegen, the Netherlands, and she's also the PI, the principal investigator for a Gates Foundation project that is aimed at implementing tNGS for drug-resistant TB detection in West Java, Indonesia. And this will be the focus of a presentation today. So thank you again, Doc, for accepting our invitation to share your experience, and over to you.
Okay, good morning, good evening, and good afternoon, wherever you are. And thank you, Lucy, for a very nice introduction, and also, yeah, a very nice opening for this session. So here I would like to share our work about tNGS implementation in West Java. So for this project, maybe I'm focusing more on the application of this tNGS for drug-resistant detection and how we can further use this result to inform the clinician to guide the treatment for drug-resistant TB patient. So this is part of a project called TARGET. So TARGET is abbreviation of Targeted NGS for Drug-Resistant TB in Indonesia, a project that is funded by Gates Foundation and also from FINE. Let me check. Okay. So this is the outline of my presentation. So first, I will explain to you about the background, why we're doing this project, and the overview of the implementation story, and how we build our lab capacity at the lab, and then how we implement and get engaged with the clinician, and also the evaluation of this technology in clinical utilization, and also the plan of how we would adopt this technology in terms of for the national TB program in Indonesia. So of course, as a background, so Indonesia is a country with high burden of TB. We currently rank third and also rank eighth in terms of the drug-resistant TB burden in the world. And currently we have problems about the treatment enrollment, which is only 66%, and also low success rate for drug-resistant TB treatment outcome. And we also identified some of the gaps. So this is from my study at my hospital. So we learned that a large number of drug-resistant TB cases is remain undetected. And we also have limited drug-resistant TB detection capacity because its complexity. And the third is also once the patient diagnosed, it's not that easy to get treatment. So most of them experience delays in treatment initiation. And lastly, they also had a poor treatment outcome. Mostly currently we have like below 75%. So this is the overview of TB diagnostic algorithm currently running in Indonesia. So first, we start from presumptive TB cases. So we use Gene Expert, so it's a MTB RIF Ultra as a screening. So whenever a patient have a presumptive, we send them to be tested for Expert Ultra, and it turns out if the result is rifampicin sensitive, then the patient will follow this treatment course. And if patient have rifampicin resistant, then the patient will have a series of follow-up testing. So first, there will be a test of, we don't no longer have second-line LPA, so we have expert XDR to detect isoniazid and also fluoroquinolone and second-line injectables. And then we also culture the sample and then test for phenotypic DST. Yeah, so this is the algorithm. Yeah, and then Indonesia is big, it's an archipelago, and this is where we located, is the west part of Java Island. And we have 27 districts here, but this is like the most populous province in Indonesia. So we have around 48 million people, and this is the largest province with contribute with highest TB sensitive or TB resistant in Indonesia. Currently, we have around 5,000 TB services that comprises of services at 39 PMDT hospitals. So PMDT hospital is the drug-resistant TB treatment center. We also have 30 community health center that can provide drug-resistant TB treatment, and also almost 1,000 community health center as a satellite of DRTB treatment. We also have 28 microscopic reference laboratory. And then we also have around 284 expert machine and 3 laboratories that can perform culture and phenotypic DST. So the target project here is an implementation study to assess the feasibility and also the economic aspect to support successful tNGS implementation in Indonesia. We have 5 big objectives. So first is to measure the diagnostic accuracy, and we measure also the impact to the clinical outcomes. We would like to know the epidemiology, like the prevalence of second line resistance for TB treatment. We also measure public health aspect about the acceptance of this technology and also the health economic aspect. So the first time we implement this project, we have collaborated with multiple sectors to support tNGS. So first, of course, we have the donors, we have international advisor, and then we have a network of drug-resistant TB management. We have the laboratory, and we also have the engagement with the national TB program and also the academician. So this is the story how we involve the stakeholder and also the healthcare workers capacity building. So we had an audience meeting with the NTP and then with the West Java Provincial Health Office and also with the network of PMDT hospital. And then we also have a refreshing training to make sure that the healthcare facility or the clinic can send us with a good quality of sample. And then we also do a monitoring and evaluation visit to this hospital, giving them feedback about the samples that they send to us and what is our challenges. And then we also just organize a clinician workshop to strengthen the clinician role for the NGS use. So this is the map of West Java. I mentioned before it comprises of 27 district and city. So this is the distribution of PMDT hospital. In total, we have 39, but currently by July, we engage with 31 PMDT hospital and 15 drug-resistant TB community health center. So this is the site where we recruit the samples. So so early 2024, I think the first 3 months we do stakeholder engagement, and then the last quarter of 2024 we do mostly training, and then around mid 2024 we develop the SOP, and then we also do trial to optimize the sequencing machine. And starting 1st of August, we roll out this tNGS for service. And from 1st of August to 9th of July, we successfully ran around 582, so almost 600 samples running under Diplex Illumina platform. Yeah, and this is the training that we have for to improve the lab capacity. So we have like training with Tino Screen. This is Alice Ferre coming to Bandung and explaining how this sequencing machine work and how the Diplex workflow work in the field. And then here we do the trial, and then we also have internal workshop. This is, I think, Anita Shures, and helping us to guide us to make an SOP. And then also we have collaborator visit. This is Jaco van Inge and also Susan Paas. So Jaco is clinical microbiologist and Susan is the biomolecular technician. So both of them giving us suggestions what we should do when we have troubles. And we also have Amy Stidman from Global Health Labs that taught us how to improve the sample by having bit-beating methods. So this is the lab infrastructure because we do this tNGS at this lab. So this is the lab. Okay, so I hope you can imagine. So this is the West Java Provincial Health Laboratory. So this is a reference lab at the provincial level. So this is the reference lab at provincial level, and we conducted a routine TB programmatic service like smear microscopy, gene expert tests. We used to do second line LPA, but we no longer use that. And then we also do culture through MGIT on LJ, and also the second line phenotypic DST. And this lab also have experience during COVID pandemic. We provide whole genome sequencing. I think maybe we run a lot of sequencing under Nexic platform. Yeah. And this is the overview. We also have, beside Expert Ultra, we also have the BDMAX to diagnose MDR-TB. And then we also have, this is MJIT, I believe you're already familiar with this. And then we have this incubator for LG and also Arctics for biobanking storage. Yeah, and then for the biomolecular laboratory, so we have the BSL2 plus. So we have this bit beater, so we have a range of automatic extraction, the Zybio, Genolution, and Alsheng. And we also have this PCR machine, and then for this for amplification. The data that I showed you was basically we run the sequencing with Illumina iSeq 100, but now we have a new machine, MySeq i100 Plus, that can run with a shorter time. We also have a Chinese company sequencing, we call MGI Atoplex G99 that can also do tNGS. And this is the larger, the high throughput machine with Nexic. Okay, so let me guide you with what we have during this tNGS implementation regarding the key challenges. So this is the how we provide the service from the bedside and then go to the lab and then go back to the clinician. So if we have presumptive TB and then they detect if the patient have rifampicin resistant, then the samples, the sputum, will be sent to our lab. And then we have the result. And then we also do routine programmatic examination. As I told you, it's like we do culture, PDST, and then also the smear microscopy for patient follow-up. So this is the result. So we report. So this is, of course, in our Indonesian language, but this is like showing the result that we send to the clinician. So this is the implementation cascade. We start early August last year. And up to now, we actually reported around 1,100 samples, but maybe around 1,154 actually arrived at our lab. And then we lost some, maybe, but 97% managed to be screened using expert. And then around 60% can be tested with with tNGS. And then this is longer, yeah, 701. And then this is the result of tNGS. So around 410, they have positive, we call it like positive sequencing quality. And around 172, they have a partial sequencing result, and 87 are not detected. So our success rate currently 87%. So 582 comes from 410 plus 172. And regarding the turnaround time, currently from the sample received until we have the tNGS result, it takes around a median of 10 days. We also see that these tNGS technical process are more complex, a lot more complex than what is written in the manual book. So in the manual, they say, okay, we do extraction, lab prep, targeted sequencing, and then we upload the data and we have the sequencing result. But then In the field, what we do is when the sample arrive, we need to do decontamination. And then we screen because we don't know the quality, because sometimes the quality of sample might not be good. So we screen the DNA level using Expert Ultra. And then if the sample result high, medium, or low, we just do optimization with bit bidding, and then it will follow the dplex workflow. But if the Expert Ultra showed very low result, then we prefer to do culture. And if the MJIT indicates the culture positive, the bacteria is there, then we harvest it, and then we continue to the bit beating and then follow the dplex workflow. And for the bit beating, we use the glass beads, and we also add the TE buffer. And then actually along the process of performing the sequencing, so pre-analytical that we learn is that we usually have suboptimal sputum quality. Yeah, so either it is low sputum volume, there is a contaminated with blood, for example, and also once we run testing with expert, we see a very low result, sometimes trace or not detected. And then the second is DNA extraction. So we need a lot of protocol adjustment using bit bidding. We spent 3 months until we get a good bit bidding procedure. So the procedure itself can enhance the DNA yield. And then although we have automatic extraction, we have Alshang, we have Genolution, we try with Promega, but it doesn't really give us enough DNA that sufficient DNA can be proceed for sequencing. So it's really challenging for us to do automatic extraction. We try many times, but then, well, not giving us good results. So we stop doing automatic extraction for now, and then try to improve the extraction and also first. And then we also have problems. Sometimes like this week, we have problem with PCR duplex. I don't know why, because sometimes it's simply the insufficient DNA leads to sequencing failure. But sometimes when we did the test with PCR duplex, it turns out that the result is not sufficient for us to continue for doing lip prep. We have certain cutoff for that, but unfortunately the PCR duplex is the result is not good enough. So yeah, people call it like there's an inhibition in samples, so they cannot be showing high DNA, so we can proceed for lip prep. And of course, for those working in the labs, you're very familiar with this step. So lip prep is always complex, labor-intensive protocol. It takes 2 days. And we also learned that sometimes there's a human error. There's a suboptimal indexing that might lead to sequencing failure. And for the sequencing itself, it's a time-consuming lab procedure. And we have to do many troubleshooting, which demand more time and also more tools. And from what we experience now, the dplex web analysis, when we took the data, the FASTQ files, and then we upload it to the dplex website. Sometimes the server performance, sometimes they quite long. And then we need to do multiple expert consultation and training to do this troubleshooting. For example, the samples like fail, we cannot really have the FASTQ, or the data is there, but it's fail in indexing. So we have to do the interpretation like somehow like manual. We send it to GenoScreen, and then they will give us the result. So all this process actually turned out to be extra time, extra cost, and more staff needed. Okay, so and then we can move on with the potential use of tNGS for clinical utilization. Yeah. So currently, of those 500, almost 600 samples, so 451 patients, they already started their second line treatment. And currently in Indonesia, since January last year, we upscaled the use of the shorter regimen using the BPAL and BPAL-M regimen. So among those with second line treatment, most of our tNGS results show concordance with the treatment regimen. So 89% that they are okay. But then we also see that tNGS showed additional resistance rather than what is identified through expert ultra and expert XDR. And then it turns out that when we wait for PDSC result, it actually concordant. So 7% is actually concordant. But then 4.2% showing a discordant result. So these discordances usually we find for fluoroquinolones and also the bedaquiline. So interestingly, of those with additional resistance, actually tNGS already identified this additional resistance sooner rather than PDST. But currently, because in our national TB guideline is still on the process of adopting tNGS, so most of the clinicians still wait for PDST result. So once it's concordant like this, the condition, then they will change their treatment regimen accordingly. So this is an example where we have a female patient, 54 years old, and there is no drug-resistant TB treatment history. So this patient's diagnosed as rifampicin resistant on August 7, and then our tNGS results showed that there is a resistance for rifampicin, isoniazid, pyrazinamide, streptomycin, fluoroquinolone, and ethionamide. And then this patient already start treatment. So it's like a week after the expert ultra, this patient start the treatment with BPAL-M. And then because our tNGS showed there is fluoroquinolone, then this patient need to have treatment adjustment. So we stopped the moxifloxacin 1st of November. So one day after the clinician have tNGS result. So, and then 5th of November, the PDST result come up, and then we learned that the result is almost the same. Like it's not almost, it's the same. So this patient has a high and low isoniazid resistant and also fluoroquinolone resistant. And then as a follow-up on January, so it's like maybe 3 months after the treatment, the patient have culture conversions from positive to negative, and this patient last March was declared as cured. So in this case, tNGS actually detect moxifloxacin resistant earlier than phenotypic DST. Can you imagine that this patient needs to take a medication, which is unnecessary actually for 2 months if we don't have this tNGS result? Yeah, so this is the result. Very clear that this patient have rifampicin, isoniazid, pyrazinamide, and also this is streptomycin and this is fluoroquinolone. So it's all resistant. Okay, and then what is the plan? Because we have a nice result. So what is the plan for tNGS integration with the National TB program? So we do tNGS cost unit based on our experience in West Java again. So this cost was calculated. We used the ISIC 100 with a maximum 13 sample per run. And of course, this cost is the cost that we calculated from clinical samples. And then we also in the workflow add isolate processing. So this second column here indicating the unit cost for isolate. So for clinical samples without isolate, so the price or the cost is around 254 US dollar. And because we have isolate, it becomes more expensive, of course, for 284. And if we just do the clinical samples and then we add about cost for facility and space, personnel and training, and also the equipment. So the final price per sample for this tNGS is 282. And then this is the last column showed the PDST cost currently in around 106 US dollars. So of course, from this comparison, tNGS costs still higher compared to phenotypic DST. However, cost effectiveness analysis is still ongoing. We tried also to measure how we can save money by not providing unnecessary drug. I mean, like the previous example, this patient, if there's no tNGS, would have taken 2 months moxifloxacin, which is not necessary. So we try to calculate from different angle, but the study is still ongoing. So as a conclusion here, this tNGS has a potential to reduce overall treatment costs if effective regimen can be decided earlier for drug-resistant TB patient. So our conclusion is to conclude. So first, this technology is feasible to be implemented in high burden and low resource setting like West Java, Indonesia. But the diagnostic network and routine monitoring evaluation should be in place. And lab workflow requires through planning, tour of planning, piloting, optimization before implementation. And even though we provide the service, the optimization is still running. Costs still high for now, so further analysis and support are needed to ensure sustainability. And as the way forward, first, we will continue advocating to the Ministry of Health to include the tNGS in the national diagnostic algorithm. We just had a meeting with the NTP last week, and we had, maybe we don't do tNGS for all newly diagnosed patients, but maybe we can focus tNGS to solve problem in complicated cases. And then we also see the possible scheme for sustainability, how we can fund tNGS tests in Indonesia and also to other labs. And then routine refreshment training and machine maintenance, and also optimize and develop a standardized tNGS lab workflow, because we hope that there will be more lab in Indonesia that can perform this test. Okay, so with this slide, I would like to end my presentation, and I would like to thank my team here. So this is the research team and collaborator. We have the big network of hospital, RC3ID, so the West Java Provincial Lab, and also the Provincial Health Office of West Java, our collaborator from Radboud, Otago, Gates and Fine. And here we are when we have the workshop last week with the clinician, where we have Anita here. Okay, so I would like to end my presentation and over back to you, Lucy. Thank you for the opportunity.
Well, thank you so much, Dr. Bony. This was really a brilliant presentation, and I think you clearly outlined what the issues are with tNGS, and I particularly liked one of your concluding sentences where you were saying you're having these discussions with the ministry to find out what's the best use case for tNGS. And I think because you brilliantly showed those costs comparing tNGS to phenotypic DST, those discussions are useful. And we know the cost effectiveness analysis that came along with the guideline from WHO did show that in settings where phenotypic DST is not routinely available, then targeted next generation sequencing becomes cost effective in that regard. So I think the take home message here is programs would need to see would need to map out what is their current capacity for phenotypic DST, and if that's not routinely available, then definitely a case is made for target next generation sequencing. But these are discussions that countries are going to need to have. And there have been a lot of questions in the chat. And one of them is around your discussion around Expert Ultra. And just a reminder to participants, I do see your raised hands. And I please ask that you could please put your questions in the Q&A box and we will get to them. I think Dr. Lestari did give us a lot of time for discussion, so we should be able to get through all the questions today. So the question around Expert Ultra is first, why are you not sequencing directly from culture and then doing the beating step? And the follow-up is around the very low expert MTB with Ultra. They say that it is known that some of this could be false positive. So they want to know what is the proportion of resistance you have from this category of patients. And then the third question around Expert Ultra as well is, are you doing this expert as a follow-up to the initial expert that would have been done in the field? And is that not a duplication? Over.
Okay, Lucy, I try. There's a lot of questions actually. Okay, so I will do it like one by one. So first, regarding the why we do another expert, because usually because in our setting all presumptive TB will be tested by expert, and then not all healthcare facility they have drug-resistant TB center for treatment initiation. So this patient need to be referred. And per guideline in our hospital, we need to screen the patient with a series of laboratory tests. The patient needs to again submit their sputum. They need to do chest X-ray. They need to do blood tests, urine tests, ECG, and a series of examination. So that's why sometimes we learn there's discrepancy between the first time the patient have rifampicin resistant and different with the second sample that we receive at the hospital. So that's why I need to do second expert ultra to make sure I don't have a false positive samples. So that's why we test it again. And on the good thing about ultra is giving us the CT value. So it's like indication of how many DNA are there, and by semi-quantitatively result, high, medium, low, or very low. So that's the idea why. So we try to prevent as much as possible, like not detected or trace or even very low to be sequenced, because I remember if there is not enough DNA there, your sequencing, it will impact, it has a negative impact for your sequencing results. So that's why I'm not going to proceed that kind of sputum. So I hope it helps for you to understand, like that's the setting.
Yeah.
And then again,
around...
for the isolate, yeah. So actually, if we have high, medium, and a good quality of sputum, we just go directly for tNGS. But then for very low, because usually the CT value is very high, it's like 36, 37. So we try to like harvest the bacteria first, to make it grow in our MJIT medium. And then when it's give us indication, oh, this is cultured positive, then we harvest a bit, and then we do extraction, and then we do bit beating first. Now we do bit beating, and then we do extraction. But to be honest, we are not having the as successful result as what we have in clinical samples. So there's still something we need to work out, because the hypothesis, if you do tNGS from isolate, you should have more bacteria there. You should have abundance of DNA there. This is something we do for for WGS, right? We cultured, we do WGS. But our experience now is mostly from the culture, we have the result, but mostly partial result. Negative result is more dominant rather than the positive or positive too. So we consult with our clinician, with clinical microbiologist, I mean. So she suggested, Joy from the ICMR, so she suggested us to, instead of using MGIT, we use the LJ. So that is something we're gonna try as a next and also try to do extraction with different methods. So we are in the process of doing that. I don't have the answer for you now, but hopefully we can share later our experience on that. And then what else, Lucy?
Those are the questions, and that's a really excellent response, Doc. Thank you so much. And there was just a follow-up on that. What about bedaquiline resistance? What trend have you been seeing
Yes.
in Indonesia?
I don't know. Is Rahma here? If yes, I can show the result we have. Wait. Um,
And again, colleagues, thank you. I can see your hands, but please do put your questions in the Q&A. We will get to all of them. Thanks. And perhaps, Doc, while you're looking for that, someone just asked if you have any issues with procurement and supply of equipment, reagents, and consumables.
I think for reagent and consumables, yeah, I think the usually it takes like 4 to 8 weeks, 1 to 2 months. We need to do that before. Yeah, this one. But so far we don't have any problem with that.
Great.
Yes.
Do you want me to ask another one while you're pulling out the bedaquiline?
Yes. Wait a moment. Yeah, sure. I
So the
mean,
other one,
you can. Yeah.
no worries.
It's very
The other
interesting.
question says, would you consider it sufficient to centralize tNGS testing at provincial reference lab levels for countries scale up?
Yes.
And secondly, would you focus on just rifampicin-resistant cases or test by NGS also for other resistances informed by e.g. BDMAX or expect XDR testing? Or would you only do this for prioritized populations? Okay, I'll let you answer those, then go to the second, because it's a long question. So answer those two and I'll tell you the third one.
Yeah, it's a question from a good friend of mine. Andrea, how are you?
Yeah.
Okay. Well, yeah. So actually, Andrea already warned me, like, because at the first time I want to be ambitious, like decentralizing this technology to other lab at the district level. But then Andrea was like, "Oh, Bonnie, this is quite sophisticated technology, a lot of optimization. So he remind me like to focus work to and then centralize this tNGS at provincial level, and I think it works for now. So, but then our aim is to make the procedure solid, so then we can share our experience to other provinces, because we have, of course, other provinces that would like to do this technology. And then in terms of tNGS, So the bottleneck still the cost, Andrea. So when people ask me like how much should I spend for this test, they always say, wow, that's very expensive. So that's why currently maybe the NTP would adopt this, but only for drug-resistant TB patients under treatment that have complicated cases. For example, once we have patient with multiple episodes of drug-resistant TB treatment. So this patient had been treated with LTR, STR, still fail, for example. And then when we would like to reintroduce, for example, bedaquiline, we need to make sure that this patient doesn't have any resistance. So there, tNGS can play a role. So that's what we suggest. And then the other question is, do you report and record tNGS data also electronically in clinical register? Yes. In the at the hospital where we provide this tNGS, they adopt the test. So this is something also we would like to advocate to the NTP so they can open special menu in our TB registration system. So this tNGS result can be registered there. So we are on the way on doing that, Andrea. Thank you
That's
for the question.
Yeah, that's
Yeah.
great, Doc. And I think as a follow-up to that, something that came up from the presentations we got from Eswatini and Mozambique is that they were picking up mutations that were not being picked up by either LPA or XPAD. So essentially the I491F mutation. Have you been seeing something similar in Indonesia, or you've not had experience with that? It's a mutation in the RPOB region.
Okay. Yeah. So let me show you the result. I honestly don't expect so many questions. Maybe 1 hour of Lucy. All these questions. Wait a moment. Let me show you this result.
You are closing out the session, the series, Doc.
This is our result. Yeah. I'm so sorry, this is in Bahasa because we just had it last week for the meeting at the national level. So this is the antibiotics resistant profile according to the gene mutation. So of course, most of our results show, resistant for rifampicin, isoniazid. So most of them like MDR, TB. But then we also had a growing number of mutation for GRA, for fluoroquinolone, so around 10%. And also we start to have around 1.9% patients with bedaquiline or clofazimine. So why bedaquiline and clofazimine? Because they share the same gene. So yeah. So we also find discrepancy actually. Sometimes we have rifampicin resistant because we have ultra, but then when we run tNGS, the result is sensitive. So it becomes sometimes conflict for the clinician because then this patient, of course, showing rifampicin resistant by ultra, but then because your tNGS is sensitive, so the patient need to be treated anyway according to our guidelines. So we are also thinking that we might we need another modality for diagnosis. So we are thinking of WGS for this kind of patient for confirmation, further confirmation.
That's
Yeah,
great.
so this is the result we have.
Yeah, and actually you've answered an additional question from someone who wanted to find out if you have any plans for whole genome sequencing to expand your surveillance or for difficult cases.
To solve, as I told you, we have this discrepancy. So mostly for quinone and bedaquiline, but also for rifampicin, we also have discrepancy. So that's why for those discrepancy, we are thinking WGS, or we also thinking of doing the sensitive micro titer. We call the MIC sensitizer. So it's a microbiology method where they have wells, and then they can also detect resistance of like bedaquiline for different type of different concentration. So we are thinking to do that as well. Because currently in our phenotypic DST, we only test with one concentration. So of course there would be discrepancy because then genotypic tends to detect resistance earlier than phenotypic DST. So that's why we need to have like a lot of concentration so we can make sure to at each concentration it will correlate with genetic mutation that we found from tNGS. So it's very interesting because then you need to do more and to research more on this to answer that. We'll
Yeah.
see.
Definitely. Thank you so much. And I think just as you probably talked about this already about the concordance between phenotypic and tNGS for bedaquiline and linezolid. But if you want to just add any additional detail to that in case the person missed it when you said it. Do you see the question around what is your concordance between tNGS and PDST for bedaquiline and linezolid at 1542 timestamp?
Yes. Sensitivity. Mm. So this is our, I would say, preliminary result. So we still have problem because for isoniazid, because either low or high dose of isoniazid both have lower performance for sensitivity and specificity compared to WHO standard. But in terms of clinical use, it's not that yeah, I don't say it's not important, but it's not that informative, I would say, because in our treatment regimen now, we don't use isoniazid. So isoniazid is important when we have short regimen with 9 months, either bedaquiline based or economic based. So that's why we this is not really a problem for us now with this. But for levofloxacin and moxifloxacin, I think we said we can have comparable result with WHO. So this blue is WHO standard for sensitivity. So blue indicated WHO standard and yellow is our result. So I think our result is comparable with WHO standard. We don't find any resistant for linezolid, so that's why our specificity is like 100%. But we can say for bedaquiline and clofazimine, yeah, it's also comparable. So I think it's good. The concordance of tNGS with phenotypic DST.
Yeah.
So far. So that's why our treatment regimen is like 89% concordance with the tNGS result.
Great. Okay, I think that's very useful. And one thing you mentioned when you were talking about the FASTQ files, and an additional question came in around data management and the requirements for storage of those sequences. What strategies are you putting in place, or any challenges you're having in that area?
I think I would like to invite Anissa to answer. So Anissa, please. Anissa is also overlapping. So over to you, Anissa.
Yeah, thank you, Dr. Bony. So actually, the WHO guidance already write the setup for our storage. So we use the WHO guidance for saving our FASTQ files. So currently we are moving, starting from the SSD or like hard disk in your lab, but we are currently moving all of our FASTQ data to the Amazon storage cloud. So there is a certain like already written for the pricing, also the setup for saving the FASTQ files.
All right, so then it's cloud-based storage, then it's not stored on your facility, is that correct?
Yeah.
Okay, all right, great. And then an additional question that just came, and I see Anissa was typing it in, but we have a few minutes to respond. Someone was asking, is it possible to use ONT since this might be more cost effective? Just following up on the issue around cost that you talked about. Over. Dr. Bony?
Sorry, can you repeat the question, Lucy?
Yeah, it was a follow-up on the issue around costs. So the person is asking if it's possible to use ONT, the Oxford Nanopore, since it has been said to be more cost effective to reduce the cost. Yeah.
So currently at our lab, we don't have the ONT platform, doctor. So we don't have that, but we now have the newest Illumina platform with MySeq i100, where they can have 48 samples and also with only 7 hours sequencing time. So this is also promising. And then I will do unit cost calculation again. And also, what interesting is also as I told you, the Chinese machine, the MGI Atoplex. It's completely different pipeline, completely different methods, how they do the sequencing, but it seems promising. And the reagent is also cheaper. But let me again calculate the unit cost first. So then we can have the same would say the same pace on understanding this unit cost, because then it should be breakdown under the indirect cost like facility, human resources, training, and then the consumables itself. But I will certainly happy to share later, because we just have this machine like 2 months ago. So it's but we run already almost 100 tests under this MGI Atoplex.
And yeah, we will look forward to those results.
Yes,
when you have them.
I'll be happy to share later. Yeah.
All right. Well, thank you so much, Dr. Lestari. And as you can see, we had a lot of questions in the chat showing that people were really interested in what you were talking about. So I'll just give you 1 minute to give us your final thoughts as we wrap up the series. Thanks. Any final words you want to share with the participants?
I thought you were gonna say the final word. Sorry. Okay. So my final word is this technology is very helpful for clinical use, because they can inform the clinician which antibiotic works and which doesn't work, especially for second line treatment. But just the bottleneck we need to solve together is this complicated sometimes in the procedure. It's not straightforward method. So we need to optimize and make sure we record it well, because then this is going to be like a model. So of course we can use Illumina, we can use MGI platform or ONT platform, but always that among those equipment, instruments, we need to optimize the workflow first until it's ready for the upscale. And I think if we can optimize the workflow and we have larger volume, I think the price will definitely a lot cheaper. And that's where tNGS can be accessible for MDR TB patients, I mean, drug-resistant TB patients, or maybe all TB patients, because it's very helpful and to prevent patients of having unnecessary antibiotics, I would say.
Thank you
That's
so
my
much.
final remarks, Lucy.
Yeah, those were excellent final remarks. Thank you so much, Doc. And again, thank you for this brilliant presentation and the exciting discussion we had around the applications of tNGS and the challenges that you're seeing. And I think your final word that we will always need to optimize this for our systems until it's accessible. And hopefully as the volumes increase, the prices will come down. So once again, thank you to everyone for attending our TB Genomics series. We've really enjoyed bringing different experts to share their experience and to share their insights on tNGS. So thank you for attending, and we look forward to having you again at the next echo session. Goodbye.
Bye-bye. Thank you for listening.